So good morning, everybody attending the meeting, and Happy New Year to all of you on behalf of the IHRS President, Dr. Ullas Pandurangi, Vice President, Dr. Vanita Arora, and the Secretary, Dr. Rakesh Yadav, and the entire EC of the IHRS. It's never too late to say Happy New Year. And we want to start this year with kind of a bread and butter topic in electrophysiology, which is supraventricular tachycardia. And the session will focus on mainly the electrophysiological aspects of doing an EP study in a patient with supraventricular tachycardia. So a little bit background about this program. This has been on now almost for 3 years, and with a great degree of regularity. Once a month, first Sunday usually starts at 10 or 11 o'clock, depending on the suitability of the speaking faculty and the center. And the IHRS faculty has been very kind to immediately agree to my request to make a program choosing a topic of their choice. The only instruction is please keep it focused to the benefit of the postgraduate so that they remain interested and learn from these programs. We also have had foreign faculty, international faculty on and off, and they have also been kind to join and share thoughts and teach on this program. All in all, it has been good. My only wish is that more and more of you can attend the program so that some of the departments do not necessarily have a full-time electrophysiologist practicing, and probably in many of the DNB centers. And I think we wanted to kind of not fill, but at least provide some solace in this void and give some introduction. So learning from here, you might go back to the books and prepare for your exit exams better. And it's also possible that you might be attracted to EP as a career in future. So that was the whole thing. And as IHRS, we have been pretty successful to keep this program moving. There have been hardly any hiccups or any reason to annul a program. And in fact, through the COVID times, it was actually a great help to reach out to the students. So we have been sending messages to the head of the departments or program directors of the respective colleges or DNB centers, and requesting them to pass on the information to their postgraduates, because the postgraduate is a floating population. So, and lately we have also involved the Sun Pharma, which has kindly sponsored this entire program and provided us with the logistic support, whereby we are able to do this pretty seamlessly. So I think there is not much more that I want to say and stand in between you and the academics. Just to introduce, this time I have requested Dr. Arun Gopi from Calicut to team up his colleagues in Calicut, the EP colleagues in Calicut, and set up a program. And rightfully so, he thought SVT was a good way to start the year. We have Dr. Kartikeya Bhargava from Delhi, Medanta, a very astute electrophysiologist, and importantly, he has co-authored a book on electrophysiology. So I think he has a lot to tell you, and he's a good teacher. We also have Suchit Muzumdar from Calcutta, again a product of Sri Chitra, and that obviously says that he will come in with a lot of good explanations for whatever Dr. Gopi's team presents. So we really have this time, the start of the year, a good combination of faculty from South, North, East, and myself a bit coordination from the West. So it's truly a IHRS program. So no much from my side. Let me request Arun to take over and tell us how he wants to go ahead with the next about 1.5 to 2 hours. Time is not a big constraint, so we can indulge in teaching as much as we like. Arun, floor is yours.
So a warm good morning to all. Am I audible and my slides are visible?
Yes, very much. Please go ahead.
Yeah. A warm good morning to all. At the outset, New Year greetings from the coastal city of South India, that is Calicut. Me along with my team, Dr. Sam Jacob, Dr. Anis Tajuddin, and Dr. Amira, extend New Year greetings to all of you and to our experts, Dr. Karthikeya and Dr. Sujit. At the outset, I really congratulate and really appreciate the hard work Dr. Ashish Nambar has put into this DNB training program, which he has been very systematic on. And even with our program, we were informed almost 2 months ahead to get the schedule in, and he has been constantly coordinating. We really appreciate the systematic approach that has been following and the regularity with which this training program has been happening. Sticking to the basics and trying to instill EP in the junior cardiologist, thereby stimulating them to take up electrophysiology as a career. So to start off the year, we thought the most common thing that we all see in our EP labs is managing SVTs or the narrow complex tachycardia. So we thought in the next 2 hours or so, our team would go on and try to put forth and try to explain the nuances of each of actually, in fact, 3 common maneuvers that we use for differentiating the common SVTs that we see in the EP lab. So these maneuvers we can deliberate for each of these single maneuvers we can deliberate long enough, but we think we'll try to stick to the basics, have the juniors understand how these maneuvers are done, how to interpret these maneuvers. So basically, when we talk of SVTs and understanding the SVTs in the lab, primarily what people getting into the EP lab need to understand is when we talk of SVTs, stick to the basics. The 3 common SVTs that you might see or you are going to see in your EP lab is the commonest one, bread and butter for all electrophysiologists, is AVNRT, which forms 65% of the SVTs that you see in the lab. The next is an orthotomic AVRT mediated by an accessory pathway, which contributes to 30% of the SVTs you see in your lab, and 5% of them would be an atrial tachycardia. So to understand how you differentiate between these 3 common differentials, you need to understand the mechanism of each of these. I'll not be deliberating deep into each of these, but to just give a bird's eye view, AVNRT is actually a micro reentry. You can see actually it's a micro reentry in the perinodal atrial tissue. And then after the micro reentry in the perinodal atrial tissue, the circuit has been a debate for long. People, after having looked at this arrhythmia for even 2-3 decades, this arrhythmia still keeps fascinating us because every case sometimes throws up a surprise. And despite this being the commonest arrhythmia, as we do more and more of this, we realize we understand less and less of this arrhythmia. So AVNRT is actually a micro reentry involving the perinodal atrial tissue. And after the micro reentry, there is simultaneous activation of both the atrium and the ventricle from the central axis of the heart. So if you understand this AVNRT as a micro reentry and then simultaneous activation of atrium and ventricle from the micro reentry point, you'll understand most of the mechanisms and how the V2A correlations happen during the tachycardia. So the key thing is it's a micro reentry around the perinodal atrial tissue, and after that, there's simultaneous activation of atrium and ventricle. That means neither atrium nor the ventricle is a part of the circuit. It's an AV node dependent tachycardia, but neither atrium nor ventricle is a part of the circuit. So you can have atrium and ventricle getting dissociated from the circuit and the tachycardia is still going on. The second tachycardia is orthotomic AVRT mediated by an accessory pathway, where you have antegrade activation of the ventricle via the His-Purkinje system and retrograde activation of the atrium via the accessory path, which forms 30% of the SVT. To understand the mechanism, it's a macro reentry. It's a macro reentry involving the atrium, the AV node, His-Purkinje system, the ventricle, and the accessory pathway. It's AV node dependent, definitely, as you see here. And it's a macro reentry with sequential activation of ventricle and atrium. So there's ventricular activation followed by atrial activation and then ventricular activation. So there's sequential activation of atrium and ventricle, and atrium, AV node, his Purkinje system, and the ventricle are integral parts of the circuit. So you can neither differentiate atrium, ventricle, or the his bundle from the tachycardia. So that's a key difference between the two. Focal atrial tachycardia is actually constitutes 5% of the SVTs you see in the lab. It's not an AV node dependent tachycardia. It's because of micro reentry in a small area of the atrium, or a focal activation, focal automaticity of an atrial musculature leading on to activation of the ventricle via the his Purkinje system. In addition to this, there are some uncommon SVTs like junctional tachycardia and orthomic AVRT mediated by a nodoventricular or a nodovesicular tachycardias. These for the beginners are more for theoretical aspects. You actually would seldom find them. Common things are common, and rare diseases you will seldom find. You'll see them rarely in the lab. So you need not spend more time on understanding and differentiating them from the common SVTs. In the EP lab, we look at two things. One is in sinus rhythm, before we already have an ECG of the tachycardia. So in sinus rhythm, we look at baseline observations. We do some pacing maneuvers in sinus rhythm. Then we induce a tachycardia. We look at the baseline characteristics during the tachycardia and then employ some pacing maneuvers during tachycardia. Just having a baseline understanding, whenever you're seeing, before you apply any diagnostic maneuver, during the tachycardia itself, some baseline observations will give us some idea of what is going on. So in typical, most of the SVTs, you will have AV association, but whenever you find AV dissociation in SVT, AVRT is out. Unless you have an autonomic AVRT mediated by nodoventricular, nodovesicular pathway. Otherwise, conventional typical AVRT mediated by a atrioventricular pathway is ruled out. So AV dissociation is seen in orthonomic AVRT mediated by nodoventricular, nodovesicular, which are rare. Typically, most of in our scenario would be seen in an AV NRT, where V's are more than A. Whenever there's an AV dissociation with A is more than V, it can happen both with AV NRT and atrial tachycardia. Typically, atrial tachycardia, where you have A is more than V. In short RP tachycardia, so when the RP interval is shorter than the PR interval, if the VA interval, which is from the onset of QRS to the earliest A, if it is less than 70 milliseconds, it typically rules out an accessory pathway. So in that case, you are either dealing with a typical AV NRT or an atrial tachycardia. Similarly, if you have a long RP tachycardia, you have three differentials: a typical AV NRT, an orthonomic AVRT mediated by a slowly conducting decremental pathway, or an atrial tachycardia. We'll be having a case-based discussion on this later on in the course of the seminar. And you look at the atrial activation sequence. That also gives us a lot of idea what maneuvers you need to employ. Anytime you have a high to low, a cranial to caudal activation of atrium, that clearly roots out anything related to the annulus. So an AVNRT or AVNRT or AVRT is clearly ruled out. Whenever you have an atrial activation sequence with its cranial to caudal, it clearly puts a diagnosis as an atrial tachycardia, or some very rarely this can happen with pathways as well. Spontaneous termination of a tachycardia with an A always rules out an atrial tachycardia. Spontaneous termination of tachycardia with an atrial signal always rules out atrial tachycardia. During a tachycardia, whenever there's oscillations, look at what is the controller. If an HH interval predicts the AA change, then it's a node-dependent tachycardia. Similarly, whenever you have a bundle branch block and there's a simultaneous increase in the VA interval, it actually means that you have an orthonomic AVRT with an accessory pathway which is ipsilateral to the bundle branch block that has happened. So this would be what we will be discussing on. So we have some, as I said, some pacing, some maneuvers which we do during baseline maneuver, during sinus rhythm, like you do Parahisian pacing, delta differential ventricular pacing, all during sinus rhythm, or you can do an AH during understand the baseline intervals during sinus rhythm. And during tachycardia, we generally would do an entrainment, say his synchronous PVC, and then Parahisian and differential entrainment again only in rare scenarios. Similarly, during tachycardia, you can also do atrial pacing maneuvers, giving his refractory APC or early APC or overdrive atrial pacing. So to elaborate on each of these maneuvers, we would not be discussing all these maneuvers. We would stick to three commonly used maneuvers, that is ventricular entrainment, his synchronous PVCs, and Parahisian PVCs. Dr. Sam in the beginning talk would be dealing with ventricular entrainment. Subsequently, Dr. Anis would be dealing with his synchronous PVCs, and then I will be deliberating on Parahisian pacing. And finally, we have everything put together. Dr. Amira discussing a case-based, three case-based scenarios where she would demonstrate each of these maneuvers, and we can have a discussion on that. So to set things in place for Sam, so we start off with ventricular entrainment or ventricular overdrive pacing, which is nothing but repeated resetting of a reentrant circuit by a pacing train. And we'll have some expert comments from the learned Dr. Karthikeya Bhargava, who's an very academic and expert electrophysiologist. And then Sam would deliberate on the commonest maneuver we do in narrow QRS tachycardia. As Dr. Sam Aslan said, whenever you're dealing with a narrow QRS tachycardia, your maneuvers are going to be start with ventricular pacing or ventricular extras. And when you're doing with a broad QRS tachycardia, you'll be starting with atrial pacing or atrial extras. So over to you, Dr. Karthikeyan.
Yeah.
Thank you, Arun. So a wonderful introduction, in fact, that sets the ball rolling. And I'll just make a few comments because most of the things have been said by you. So whenever you have a narrow QRS tachycardia, ventricular pacing maneuvers, as he rightly said, are the ones which are needed. And if you have an atrial or a wide QRS tachycardia, then atrial pacing maneuvers are more helpful. And this is in general. Having said that, if you have a clearly a narrow QR or a supraventricular tachycardia with a wide QRS, that is with right bundle branch pre-existing during sinus rhythm, or you have a bundle branch block during tachycardia with a normal or an equal HV interval that during sinus rhythm, then you are sure that you are again dealing with a supraventricular tachycardia. Especially during an electrophysiology study, sometimes you may, while placing your his catheter, you may traumatize the right bundle branch and may result in a right bundle branch block, which is traumatic, catheter induced. And so any supraventricular tachycardia that you will induce during that study will continue to have a wide QRS because the baseline now becomes a wide QRS. And in these situations also, ventricular pacing maneuvers have the same significance as in any other narrow QRS supraventricular tachycardia. And having said that, one of the most important maneuver out of a list of many is what is called as ventricular entrainment, wherein we pace from the right ventricle at a slightly faster cycle length, faster rate, that is a slightly shorter cycle length than during tachycardia from the right ventricle, and then look at the response when we stop pacing after 8 to 10 beats. And that's what Dr. Sam will be talking about in his presentation today. And so we'll listen to him and then we can maybe discuss more. So I have found that this maneuver is the one which is the most useful in most of these common variety of supraventricular tachycardias. And one thing before he starts, I will just like to make a comment that although you may recognize the tachycardia by just looking at the baseline observations during sinus rhythm, and looking at the pattern during this induced supraventricular tachycardia, it's always important to do one or two maneuvers because sometimes you may be fooled by the pattern recognition, although most of the times you will be correct just by looking at the electrograms during the induced tachycardia. So it's always a good idea to, before you start on identifying the target of ablation and start ablating, uh, do at least one or two pacing maneuvers, which will help you in confirming your diagnosis, what you have made by your baseline observation and pattern recognition of your SVT. And having said that, it is again very important not to use maneuvers which will confuse you more. So you need to understand what you are going to achieve by doing any pacing maneuver. For example, if you want to differentiate between, say, AVRT and AVNRT, you have already ruled out atrial tachycardia. The best one would be to do a pacing maneuver from like a his synchronous PVC, which will help you in differentiating the two. But if your idea is to differentiate AVNRT from atrial tachycardia, then the his synchronous PVC may not be of that great use. So you need to know which pacing maneuvers to use so that you come to a final conclusive diagnosis in your study before you start ablating. So with these words, I will invite Dr. Sam Jacob to
Yeah.
present his
Just
present.
just one thing, Kartikeya and Arun. Great introduction to the seminar. I just invite a very simple comment from Suchit. A tachycardia is going on. You put a catheter in the his bundle region. How does the HV help you?
Yeah, actually, I think Dr. Bhargav Karthikeya sir has already touched on. If the HV is same as a sinus rhythm HV, it's most likely a supraventricular tachycardia, which we are dealing with. And if the HV is becoming becoming narrow or something, then we have to think of other differential diagnosis. If the HV is more than a sinus rhythm, then some differential of a bundle branch reentry VT and all these things can come. But these are all wide QRS tachycardias.
Right. So, and a short HV can mean a pre-excited tachycardia or a ventricular tachycardia when you are dealing with a broad QRS tachycardia. Sure. I think that's enough of an introduction, and we'll let Sam do his presentation. Sam, please come in.
Good morning, everybody. Happy New Year to all of you. Can you see my screen? Is it visible?
Yes, all good.
Yeah. So I'll be doing probably the most basic and probably the most important one of your pacing maneuvers, which is ventricular overdrive pacing or ventricular entrainment. So why do we basically do it? Is to differentiate all the narrow complex tachycardia, whether it's AVNRT, AVRT, or an atrial tachycardia. This is one of my favorite quotes, which goes, "Excellence is doing ordinary things with extraordinarily well." So the same with ventricular overdrive pacing. If done really well, it'll rule out 90% of your SVTs. It gives you a diagnosis as to what it is. So doing a good or a very good ventricular overdrive pacing can solve all of your problems. So I'll just start with a simple ECG. There's a 37-year-old female who comes to you with recurrent palpitations. So in this ECG, it's you can see that the P, it's a long RP tachycardia, which means all your three differentials are still open, which is an atypical AVNRT, atrial tachycardia, and AVRT with a slowly conducting accessory pathway. So the mechanism of SVT, what Arun sir already told, is that one is a micro reentry, one is a macro reentry, and the third is just a focal tachycardia. And as per the age, the chance of each of them do change. So if the younger age group, you will seem to see AVRT more. And in the middle age group, and the most common patients that we see will be more of AVNRT, followed by atrial tachycardia. And as Arun sir already mentioned, 65% of our patients are AVNRT, 30 patients will be AVRT, and around 5% will be atrial tachycardia. These are the usual catheters we use for the DNB students. We're just trying to say that the numbering of the catheters, that is 1, 2 is always at the tip, and then we number them as we go more proximal. So it's 1, 2, 3, 4, 5, 6. As we go proximal, we number them that way around. And for most of the SVTs, we normally use 4 catheters as a study. So one is placed in the RV apex, one is placed in the CS, the third is on the HIS, and the fourth in the HRA. So again, for the DNB students, you should realize that the CS is actually, it's between the atrium and the ventricle, so it'll pick up the signals from both left atria and left ventricle, so you'll get both the signals from on the CS catheter. And for the HIS catheter, you are across the tricuspid, so you get the atrium, HIS, and the ventricular signals on the HIS catheter. RV apex and HRA will be only atrium and only ventricle. This is just a baseline how it normally looks. So you tend to have a sinus beat going from the HRA, followed by the HIS, and then the ventricle. So how do you know which is HIS and ventricle? Is normally look at the QRS. All the signals on the QRS tends to be the V ventricle, the V, and the others you have the one prior to that is normally the atrium. And if you can look at, you can see a small HIS here, which have been marked. So this is to measure the HV interval in an accessory pathway. So the first step was always to induce an SVT. We do that by first doing a atrial decremental pacing and a burst pacing. The decremental pacing goes on till we reach the AV Venki backing cycle length. Then we do an atrial extra stimuli where we start with an S1, S2 of either 600, 500 or whatever you're comfortable with. Usually the S2 will be just 20 milliseconds less than the S1. We decrease the S2 by 10 till we reach the AV nodal ERP. And during the procedure, if the SVT is not induced, look for an AH jump if possible, which gives you an idea that there is a dual node physiology already. If the atrial extra stimuli doesn't work, you can always try consider ventricular extra stimuli and also isoprenaline for inducing the SVT. So the patient with that ECG that I already showed you, just starting off with a tachycardia being induced. It was induced by an atrial extra stimuli, and this was the tachycardia. So as Arun sir already pointed out, at the baseline itself, we can tend to make a lot of differentials. So starting off the first part, as I said, look at the V to A relationship. So you have V equaling to A, that is every single ventricular stimulus has a atrial signal also. So both the signals is 1:1. So thereby which all three are still available. Then you look at the VA. So how do you measure the VA? You pick up the earliest point of the V, which is usually on the QRS, till the earliest atrial activation. Here in this case, that's CS56. So you look at the VA and measure this. In this case, it was 180 milliseconds. And as I said, we look at something which is, if it was less than 70, we would have ruled out AVRT. But in this case, as you can see, the VA will be more than AV, that by which all three tachycardias are still open. You can always look at the atrial activation sequence also. In this case, again, it is not high to low. When they say high to low, you mean the atrial HRA being the earliest and then coming lower. In this case, again, CS56 is the earliest. So it's an eccentric, probably somewhere close to the AV node. So you have AVRT and atrial tachycardia or an atypical AVNRT still available. So these are the changes that you look at the initial, once the tachycardia is induced on your screen. At this point, you just have to stay calm and perform a VOP. Once we do a ventricular overdrive pacing, how do you do it? You measure the TCL during the SVT, pace from the RV apex around 10 to 40 milliseconds faster, pace until the QRS stabilizes for 5 to 10 beats. Then beyond that QRS stabilization, look for atrial advancement. And once the atrial is advanced, you can stop the pacing. So you have transition zones, as you would have in this point. Initially, you will not be able to capture any of the myocardium, followed by a fusion kind of a beat, followed by an increased fusion if there is an AVNRT, and then a complete, then you'll capture your atrium in an AVRT. But an AVNRT, you might not get a fusion beat because once the ventricle starts getting captured, it will block the exit of the tachycardia lesion from tachycardia beat from the conduction system. So you tend to not get fusion beats during your AVNRT, and a fusion beat is generally seen in AVRT. So once you start performing and you see this transition zone and you see a fusion beat, there's more likely the chance that the diagnosis is an AVRT and less likely to be an AVNRT or atrial tachycardia. This is just a slide on differential entrainment. I know it's a little difficult, this one, but still, so if you're pacing from the RV apex in an AVRT, you tend to block the exit of the normal conduction beat. So you will not get any fusion in a AVRT if you're pacing from the apical site. But if you change the site to somewhere near the basal area, you might actually entrain the tachycardia, but not and allow the original tachycardia beat to come down, by which you get a proper fusion. So this fusion will again give you an idea that's an AVRT, that is the probable tachycardia. Then once we stopped the pacing, the first thing that we look for is something called as post-ventricular overdrive pacing response. So what happens is, we know that this is the tachycardia. In a case of an AVNRT, that it's a micro re-entry. So we are pacing from here, we go in, we've kind of entered the tachycardia, and then we stop pacing. So once we stop pacing, the beat that was already in the cycle will come down the slow pathway, and then will again come down to depolarize the QRS along with the atrium. So you tend to get a V response, where you have the V first, that is the pace rhythm, followed by the atrial and the ventricle response happening at the same time. So this is how a AV-RT response of post VOP would be. While in AV-RT, it's the same thing, because we're again going up the atrium. So once we get the ventricle, it goes into the atrium, followed by coming down to activate the ventricle. So you still have a VAV response even in AV-RT. But in atrial tachycardia, we are actually overdrive suppressing the focus. So you tend to have a VA followed by the atrium firing, and you get a V. So you get a VAAV response in a patient with atrial tachycardia. So this post-VOP response itself will clarify whether you're having a AV-RT, AV-RT, or atrial tachycardia. At least it's the fastest way to rule out an atrial tachycardia by just looking at the post-VOP response. So in our case, again, we did the same thing. This was the RV entrainment. You can see that it is completely paced rhythm here. And we look at the response. So we stopped pacing here. So we got the V, A, and a V, or VA, H, and a V response, by which you roll out that atrial tachycardia for this long RP tachycardia has already been ruled out. With that eccentric pattern, it's most probably going to be a AV-RT. So if it was a atrial tachycardia, the response would have been V to an A, followed by an A and V. So you get VAAV response in an atrial tachycardia. Then always be careful about something called a pseudo VAV response. So this happens typically in a patient who's got dual node physiology. So what tends to happen is the ventricle that is being paced here, all right, this will take a long time to reach the atrium. So this V happens to be, this A happens to be a response to this V, and this A happens to be a response of this V. So if you look at this, it looks like VAAV, but in actuality, it is only this V. This relation is this A and not the preceding A. How do you make out the difference? Is by measuring the AA interval, that by which is 360 and 360, that by which that was your pacing protocol, and 380 was your tachycardia cycle length, that by, which shows that this has to be a VAAV response. And this can, this is possibly a mistake that can happen while doing reading a post VOP response. All right. The next thing that we look at is the post-pacing interval minus TCL and SA minus VA. So what do you mean by SA minus VA? Is basically, now in an orthotomic AVRT, we will be pacing from the RV apex. So if you're pacing from the RV apex, as Arun sir already told, the atrium and the ventricle is part of the AVRT circuit. So we are pacing very close to the circuit, and the time taken for the stimulus to enter the tachycardia circuit is going to be very, very small. So this is what we're measuring by looking at SA minus VA. While in AV and RT, since the circuit is at the AV node, the time taken for it to reach up and enter the circuit is going to be longer. So you're going to get a longer value. So if an SA minus VA is less than 85 milliseconds, you can be sure that it's most probably going to be AVRT. And if it's more than 85 milliseconds, it's going to be AV and RT. So in our case, we saw that the VA was around 180 milliseconds. I'll come to that. And this is for post-pacing interval. The post-pacing interval works kind of similarly. What we do here is the AV and RT, the circuit is happening in the AV node. It's a micro reentry, as I said. Now we are going pacing from the RV apex. It takes time for it to reach the conduction system and then reach the circuit and enter the circuit to reset the whole circuit and then come back. So the time taken for it to go up, when we stop pacing for the next tachycardia cycle to come in, will be the time taken for this stimulus to go up, all right, go around the whole circuit and then come down. And the tachycardia cycle length was the time that is taken for the whole cycle length for the whole circuit to go around this circuit. So you're going to get an extra time of the time taken for it to, from here, to enter this conduction system and then travel up and down and then come back and activate this. So you're going to get so much of an extra time. While in AV-RT or an orthotomic reentrant tachycardia, what is going to happen is the circuit is part of the myocardium, so it tends to enter more quickly and then come out more easily. So this PPI is going to be low. So a PPI minus TCL of less than 110 milliseconds is usually AVRT, and anything more than 110 milliseconds is going to be AVNRT. So in our case, we did the same thing. The cycle length, the tachycardic cycle length was 320. We paced at 290, what is 30 milliseconds faster. We saw that the HA has been captured. Already showed you that's a VAV response, that by which we've already rolled out atrial tachycardia. And now we look at the PPI minus TCL and the SA minus VA. The SA, the VA was already measured as 180, and this would be your VA. That's from your stimulus to the earliest A, which is 230, making it 50, which is less than 85. And same thing with PPI minus TCL, which is again 380 minus 322 that we had, which is around 60, which again is less than 110, proving that this is most probably an AVRT. So what are the issues of getting this done is that sometimes we cannot entrain the atrium, so we are not sure if we've got the, we cannot measure the PPI minus TCL, or the SVT does not continue after the SVOP, so we cannot measure a PPI or TCL. So in short, once we do a ventricular overdrive pacing, we have look at the septal VA interval. If it's less than 70, you've ruled out AVRT. You just have to look if it's AAH or AH after a VOP response. If it's AH, it's an atrial tachycardia. If it's AH, it's a typical AVNRT. If the septal VA interval is more than 70, again, look at the response. If it's AH, it's again atrial tachycardia. If it's AH, or if you cannot make out where the AH is, you look at the PPI minus TCL. If the PPI minus TCL is less than 110, it's an AVRT. Or if it's other way around, that's more than 110 with more than 85, it's an AVNRT. Thank you.
Yeah. Karthikeya, very
Yeah, so
simplistically.
nice,
Yeah.
nice presentation, Sam. So just to simplify for our students, now whenever you have a supraventricular tachycardia happening, and then you pace from the ventricle at a slightly shorter cycle length, meaning a slightly longer, higher rate, you are now pacing the ventricle, so the rate will become that of the paced cycle length. Now, if you have a situation like the circuit is an AVRT, orthodromic AVRT, where the antegrade conduction is occurring over the AV node His-Purkinje system and retrograde over the pathway. Once you pace during the tachycardia, the paced wavefront has two wavefronts. Paced stimulus has two wavefronts. One which goes towards the accessory pathway and then accelerates the tachycardia to the paced cycle length, and the other one which fuses in the myocardium, ventricular myocardium, with the incoming wavefront of the tachycardia from the previous beat. And this results in fusion in the myocardium, ventricular myocardium, resulting in change in the QRS morphology. So your QRS morphology is fused, and it is neither that of totally paced QRS nor that of the supraventricular tachycardia alone. However, when you have an atrial tachycardia, you have only one pathway from conduction from A to V, that is the AV node His-Purkinje system. And once you pace the ventricles and you find that the atrial rate has accelerated to your pace cycle length, that means that the pacing is going through the AV node His-Purkinje system and accelerating the atrial rate. And since it is using the AV node His-Purkinje system, it cannot come back again through the same AV node His-Purkinje system, because that is refractory. And so once you stop pacing, it goes, the last pace beat goes to the A through the AV node His-Purkinje system, and then the tachycardia resumes again, and the first beat is then atrial beat, and then it comes back to the V through the AV node His-Purkinje system, which has now relieved of its refractoriness. So in that scenario, you will get a VAAV response. But whenever you have two pathways of conduction from A to V, it could be either slow pathway and fast AV nodal pathway. It could be an fast AV nodal pathway and an accessory pathway. Then you will get a VAV response. So that is one thing. And this was way back in 1999 when Fred Muradi's group published their first paper showing that how one can easily differentiate or rule in and rule out atrial tachycardia with this simple maneuver. Again, couple of years later, again, the same group actually published their data saying that if we do this maneuver, we can not only rule in and rule out atrial tachycardia, and but through these measurements that Sam just showed, we can actually diagnose whether it is AVNRT and AVRT. And the principles behind these measurements is that if you're pacing from the far away from the site of the reentrant circuit, your measurements are going to be longer. So in AVNRT, the circuit lies in the AV node and the perinodal atrium, which is far away from the pacing site, which is in the right ventricle. And so your measurement, that is post-pacing interval to minus tachycardia cycle length and STIM2A and VA difference are much, much longer. On the other hand, if you have an AVRT, which has ventricle as part of the circuit, your pace site in the right ventricle is close to the circuit, and so your these measurements are shorter. So this is in principle how you can differentiate atrial tachycardia, AVRT and AVNRT by this simple maneuver. I'll not go into the complexities which Sam actually touched upon, like differential pacing entrainment from different sides, Parahisian entrainment and whatnot, but those will are useful in only few cases, but one needs to understand the principles behind the entrainment and how to differentiate the three different most common SVTs using this simple maneuver.
Karthike, for a little clarity, I want to have comments from you as well as Sam as to, for example, you are doing a ventricular pacing and you have a VA dissociation. He talked all the way about having the VA association with the atrial activation sequence looking similar to what it is during tachycardia. Let me ask you, during ventricular pacing, you have one scenario where there is a VA dissociation and a second scenario, for example, where the atrial activation pattern changes. How do you interpret these two? And the second is, it matters how fast you pace. You and Sam very clearly said 20-30 milliseconds faster than the tachycardia cycle length. If somebody unknowingly paces, say 80 milliseconds or whatever, too fast, then what mistake is he making when he sees a dissociation and can wrongly interpret things? A little clarification on these two aspects.
Yeah, so these are all very important points. So whenever you have an SVT and you want to do ventricular overdrive pacing maneuver, you need to pace slightly faster. That is your tachycardia cycle length. If it is about 300, you pace it around 280 or 270, not faster than that. And so the reason is that if you pace much faster, there may be changes, decrementation during VA conduction, or the tachycardia may terminate. And so your results may not be appropriate and your intervals that you measure may not give you a correct interpretation. So the other questions, I would again say that the way we do it, like for example, if you have a tachycardia at say cycle length of 300 milliseconds and you are pacing in the RV at 280 milliseconds for about 8 to 10 beats till you find that your QRS morphology has stabilized, then you stop pacing. And the first thing you have to look at whether your atrial rate has been accelerated to the tachycardia, to the paced cycle length. And even before that, you need to see whether once you stop pacing, whether the tachycardia is continuing or not. If the tachycardia terminates, most of the time the pacing maneuver is not very useful. If the tachycardia is continuing once you have stopped pacing, look whether your atrial cycle length has been advanced to your pace cycle length. If it has, then the next step is that means the atrial acceleration has been there to the pace cycle. And then your next step is to look at whether it is a VAV response or VAAV response. If it is VAAV response, that means it is atrial tachycardia and you get your diagnosis. If it is VAV response, then it could be either AVNRT or AVRT, and then you need to do all these measurements, which again, if the cutoffs, if the measurement differences are larger than the cutoffs, then suggest AVNRT, and if they are shorter, then it is AVRT. On the other hand, when you pace and you find that the tachycardia continued, however, the atrial cycle length did not accelerate to your pace cycle length, that means you have dissociated the ventricles from the tachycardia with the tachycardia continuing. That just means that the ventricles are not part of the circuit, and so you have excluded AVRT with the typical atrioventricular accessory pathways. So you are left with either atrial tachycardia or AVNRT as the possible diagnosis. And so you will have to do some other measurements, some other maneuvers to differentiate the two. And one can actually repeat the same maneuver after giving isoprenaline sometimes when you find that once you have isoprenaline, your PA conduction has improved. If you repeat the same maneuver, then you may find that now your atrial cycle length gets accelerated to your base cycle length, and then you can just follow it up. If even with isoprenaline it does not happen, then you have to look at other maneuvers, and typically atrial pacing maneuvers are sometimes more useful in differentiating AV and RT with from atrial tachycardia. Other simple thing which you can do is pace the ventricles very fast compared to the cycle length. And if you find that the tachycardia still continues despite VA dissociation at much faster pacing, that practically rules out AV and RT and suggests atrial tachycardia as the diagnosis. But theoretically, you still are not very sure that you have ruled out AV and RT. But for all practical purposes, this suffices that you are dealing with an atrial tachycardia and not AV and RT.
I think that's a very good explanation for some of the questions that I asked. Can we move further, Karthikeya?
Yeah, sure.
Right. So I think we can request Anis to make his presentation, and Suchit will moderate the next segment.
Thank you. Uh, hello. Dr. Anis Tajuddin will present his presentation on his synchronous PVC. This is a very important thing, especially when the tachy gets terminated easily by entrainment and all these things. So often his synchronous PVC is easy to put in that place. So Anis sir, please. Hello.
Yeah, Anis,
Yeah,
you can share your screen. Yeah.
I'm audible.
Yeah, sir.
So, yeah, I think for the sake of the audience, I have made it little a simplified presentation for his sync PVC. Am I audible?
Yes,
Yeah,
Anis, very much, and I am happy that it is simple. This is purely for the cardiology postgraduate, so you can simplify it as much.
Yeah, thanks. So, so when you look at the ECG of any rhythm, you are only visualizing the depolarization of the atrium as a P wave, and the QRS complex, which is depolarization of the ventricle. So in between, there is AV nodal conduction and conduction through the His-Purkinje system, which you do not see in the ECG. This is the same case in tachycardia. But if you look at the AV node, there is an AV nodal approach. There are two usually AV nodal fast and slow pathways, which we'll discuss. Then there is a compact AV node. Then there is a His-Purkinje system and bundle branches, which finally results in activation of the ventricle, which produces the QRS complex. So when you look at SVTs, you have to consider that the AV node has two pathways, the slow and fast pathway. Fast pathway is represented in blue because the x-axis is time, so it is very fast. Slow pathway takes more time to activate the compact AV node. And if there is an accessory pathway, in simple terms, there is a muscular or a tissue which represents ventricular muscle-like tissue connecting the ventricle to the atrium, which is by its nature fast conducting, but often we find slow conducting accessory pathways or accessory pathways which have decremental properties. So when there is so if there is an accessory pathway in sinus rhythm, normally it can be concealed when there is conduction only through the AV node, and the QRS will be narrow. If the accessory pathway conduction gets completed, at least part of the ventricle gets depolarized, and so there will be evidence of delta wave in the ECG because that represents activation of the ventricle via an accessory pathway. This is a typical circuit for AV NRT. Here we can see there is a fast pathway, slow pathway, but the entire circuit is supraventricular, or it is even before the His bundle signal is recorded in the ECG. So, or in the EP study. So the AV nodal circuit and the fast pathway, slow pathway, everything is, superior to the His signal in the So if you look at the typical AV-NRT ladder diagram, there is conduction through the slow pathway in the AV node, then a rapid conduction down the His-Purkinje system, which gives rise to the QRS complex. The QRS is represented as a small circle, which means the QRS is narrow. From the compact AV node, or even before the compact AV node, the circuit goes back into the atrium or through a fast pathway. The circuit can be entirely within the AV node, slow pathway, fast pathway, slow pathway, fast pathway, like that. But atrium gets activated during the retrograde fast pathway activation in most of the cases. And so you will get a P wave, which falls on timing with the QRS. So QRS is immediately followed, or within the end of QRS, you will get a P wave. So this is the typical AV-NRT. And this gives rise to the AV nodal reentrant tachycardia, typical ECG of absent P waves in QRS, or a P wave immediately after the QRS, which is a short RPSVT. Now, short RPSVTs are also possible because of AV-RT or some very rarely atrial tachycardias. In the typical version of atypical AV-NRT, that's a fast, slow AV-NRT. The antegrade conduction is through the fast pathway, retrograde conduction is through the slow pathway. Again, the circuit is only within the AV node. Atria gets activated and ventricle also gets activated. But here the atrial activation happens after slow pathway conduction. So it's a long RP tachycardia. The QRS happens, and then after a long time, because of slow conduction through the slow pathway, the P wave happens. So it's a long RP tachycardia, as you know. Now, when there is an accessory pathway, in the typical AV-RT, you get a fast pathway conduction through the AV node, then a rapid conduction through the His-Purkinje system, and retrograde conduction of the accessory pathway to produce the P wave. So it's a narrow QRS tachycardia, and it's a short RP tachycardia because the P wave happens within a short time after the QRS complex, because this is a fast conducting pathway. It conducts very fast up. Now, when the tachycardia is ongoing like this, you are giving a stimulus in the ventricle. So this star signal here represents a pacing stimulus which we have given during the tachycardia. So what will happen to the QRS complex? This QRS complex here will be no longer a narrow QRS like in SVT, but it will be a paced QRS complex. So that is the mark of ventricular capture when you are giving a His bundles, timed. So this QRS complex is given in such a way that the ventricular activation happens along with the antegrade conduction of His bundle. So whenever the antegrade His is anticipated at this time, you can see, and then the ventricular activation is given. But sometimes the activation through the His bundle that activated through the His-Purkinje system, even though the QRS is wide. So you get a fusion complex. The QRS, resulting QRS is not a completely paced QRS. It is a fusion between the paced QRS and the narrow QRS conduction produced through the His-Purkinje system. That can happen. And that is a phased, that indicates a fused complex by pacing. And whenever you find a fused QRS complex, which is not exactly matching the paced QRS complex. You can look at the paced QRS complex morphology by pacing the ventricle faster. If you pace a ventricle faster in sinus rhythm, in tachycardia, or in sinus rhythm, if you are pacing the ventricle, you will get a specific QRS morphology. But the QRS morphology often you get when you give a His synchronous PVC is a fused QRS complex. So when you get a fused QRS complex and the timing of the paced stimulus is such that it falls on the His bundle signal, what happens next is very crucial. Because if there is a fast conducting accessory pathway, this signal can enter the fast conducting accessory pathway. And if it gets into the fast conducting accessory pathway, it will advance the next A. So if you measure the AA interval, whenever a VPC is given, the AA interval can shorten. This happens only if there is an accessory pathway. If it is a truly AVNRT or atrial tachycardia with no accessory pathway, even if you give a fused QRS complex or his synchronous PVC on timing with his, the atrium will not get advance. The advance means you should be able to show that the AA interval measured in the CS catheter or any other catheter is premature by at least 10 milliseconds. So once it is advanced, then the next thing you have to look for is whether that has reset the tachycardia. The tachycardia itself is advanced, or only the A is advanced, but the tachycardia BV interval or HH interval does not change. That indicates that there is advancement of A, but the tachycardia is not reset. So this is the typical use for his synchronous PVC. His synchronous PVC on timing with the His bundle advances the retrograde atrial activation by at least 10 milliseconds. The important thing is to give the signal, the stimulus in the ventricle at the time when the antegrade His is getting activated, or at least just before the H is anticipated. From the His bundle activation, it takes around 45 milliseconds or 50 milliseconds for ventricular activation to start from after the His signal is recorded. So even if you give the ventricular stimulus, the extra stimulus just in front of the His Purkinje system and get blocked on the His Purkinje system, but can conduct through the atria only if there is an accessory pathway. Now, in the case of AVNRT, because the His Purkinje system is the only pathway available, not an accessory pathway, if you give a stimulus in timing with the His, because His is already activated, this stimulus cannot go upward. It will fuse in the His Purkinje system. So you will get either you will get a fusion complex if you are giving the QRS little or earlier, so that it allows the signal to some of the signal from the His Purkinje system to reach the ventricle, or if you give it at the timing of His, this signal will enter the right bundle and creep into the His Purkinje system, so that it blocks in the His Purkinje system and it cannot go into the atria, so it will not advance the atria. So the evidence of an accessory pathway is His refractory VPC advancing the next A. So that is very crucial, and that indicates the presence of an accessory pathway. If it resets the tachycardia, it indicates AVRT, and that pathway is participating in the tachycardia circuit. However, if you give a very premature stimulus, see here, the tachycardia is ongoing. It is an AVNRT. It's a slow, fast pathway. But the signal which is given is very premature. It is much earlier than the anticipated His signal. If you give a very premature signal, this signal, the ventricular stimulus, can enter the right bundle branch and enter the His bundle, and then through the fast pathway, reach the atrium and advance the atrium, and also can reset the tachycardia. So make sure that when you are giving a His bundle when you instruct the EP tech to give a His synchronous P, and you're looking for shorter and shorter, a shortening of the AA interval, make sure that the signal given is not too premature, that it is much earlier than the His bundle signal. So that's very crucial. So this is one case. This is a narrow QRS tachycardia in a patient with, if you look at the ECG here, during atrial pacing, the tachycardia is induced. During atrial pacing, there is evidence of wide QRS, that is pre-excitation. And then it sets up a narrow QRS tachycardia once the tachycardia starts. So the mechanism is the stimulus gets blocked in the accessory pathway. So no longer a wide QRS complex is produced, but it conducts down the His Purkinje system, and retrogradely it conducts up the accessory pathway. So from the ECG itself, you know that there is evidence of an accessory pathway. But the tachycardia induced is QRS, or almost there is some confusion. The earliest A is not very far away from the QRS complex, so sometimes it can be AVNRT. So here you can, in this situation also, you have to give a His Purkinje, His synchronous VPC. So here you give a synchronous VPC here. This is how you give. You time the stimulus to the RR, the signal in the RV distal. And then you start at just below the cycle length of the tachycardia. And then you give more and more premature stimulus. And finally, the stimulus actually is falling on the, so you see the tachycardia, his signal catheter during tachycardia shows H, V, and A. The earliest A is probably in the CS proximal catheter, H, V, A. And after the next H is given, the stimulus is given immediately after the H, though it's a his synchronous PVC timed to the his bundle. But then you look at the next A, you find that the A is advanced. The A is, instead of 264 milliseconds, the AA interval, now the AA interval is 246 milliseconds. So advanced by around 18 milliseconds. So this indicates that there is accessory pathway conduction during tachycardia. And then it resets the tachycardia because the next cycle length of the tachycardia is the same as the usual tachycardia. And so it indicates that the pathway is part of the circuit. So this is how a his synchronous PVC is given in a narrow QRS tachycardia. In this case, a short RP tachycardia, where there is some doubt whether it is AVRT or AVNRT, and you give a his synchronous PVC and it advances the retrograde and shows that the pathway is actually participating in the tachycardia. Sometimes it may be a fortuitous VPC. Sometimes like this, the tachycardia is ongoing. So this is a narrow QRS tachycardia. So here also you can see it is a long RP tachycardia here. So V is there, H, V, and A. You can see is the his bundle signal, then the ventricular signal, and then the A signal. So it's a long RP tachycardia. So what happens here? Here, the next H is expected here. See. And there, at that point, there is a premature ventricular stimulus happening. And when after the ventricular stimulus, the AA interval is advanced. So instead of the AA interval of 438 milliseconds, the interval is the AA interval is now 396 milliseconds. So it's a slightly premature PVC, but we can see that the AA is advanced. Again, it indicates that probably there is an accessory pathway, long RP tachycardia. So whenever long RP tachycardia is considered, it atypical or atrial tachycardia or slowly conducting accessory pathway. Here, a VPC at the time, around the time of his bundle, advances the next A and resets the tachycardia, indicating that this long RP tachycardia is due to an accessory pathway mediated tachycardia. And in this case, it is a slowly conducting accessory pathway because it's a long RP tachycardia, like a PJRT. So this is another observation you can find. So here what is happening, if you look at this is a tachycardia, again a long RP tachycardia, AHV, AHV, and then the a stimulus is given in the RV catheter in time with the his bundle. So the timing is exactly at the time of his activation. So the QRS complex is due to the pacing capture. And after the QRS complex, there is no retrograde A or the tachycardia terminates. So as one differential diagnosis of long RP tachycardia, is atrial tachycardia. But a ventricular stimulus given at the time of his, if it terminates the tachycardia, can it be an atrial tachycardia? No, because the signal has to travel up the atria and influence the atria by advancing the A. And then only if you terminate the tachycardia, it may be an atrial tachycardia. But here, it has terminated the tachycardia without producing an A. And even AVNRT, it's ruled out because AVNRT also, the stimulus will not enter the AV nodal circuit when you are giving a ventricular stimulus at the time of his bundle activation, as I mentioned earlier. So when the ventricular timing is at the his, where when the tachycardia terminates, it indicates that the tachycardia is a pathway mediated or accessory pathway mediated tachycardia. So there are different varieties of it, but we'll not go into details of long RP tachycardia, which is terminated by premature ventricular stimulus, which is timed to his. but this also indicates that there is an extra nodal pathway through which the stimulus has entered, influenced the tachycardia circuit, and terminated the tachycardia without producing a retrograde A wave. So sometimes nodovascular tachycardias can happen, or sometimes even an accessory pathway like long-acting, slow-conducting accessory pathways of PJRT can also terminate like this. So his synchronous PVC, as I mentioned, you can use in narrow QRS tachycardia, but even in wide QRS tachycardia, there is no way of clearly knowing that this is a his synchronous PVC, because wide QRS tachycardia can be an antitromic tachycardia where the circuit does not involve the AV node. Antitromic tachycardia means pathway to pathway conduction can happen. So here it's a wide QRS tachycardia, and in the you can see the retrograde atrial conduction, which is earliest at the RA, proximal RA, in the lateral tricuspid annular region. So here the stimulus given in the ventricle during just before the anticipated QRS complex, it produces a fusion complex, and here you can see that it has advanced the tachycardia cycle. Tachycardia cycle length was 358. But after the stimulus is given, it has advanced the tachycardia by 18 milliseconds with the same retrograde activation sequence. It indicates that this wide QRS tachycardia is mediated at if it's a antigradely there is wide QRS and negative HV, so it's a pathway mediated antitromic tachycardia. But retrograde circuit is also pathway mediated by producing a premature ventricular stimulus. It has advanced the A, and so it indicates a VA linking and a retrograde accessory pathway. This is another example of, even though we do not understand sometimes why the pathway, why the tachycardia terminates when you give a his synchronous PVC, it is very important to document what you are seeing. This is from a publication of a nodovascular, nodoventricular tachycardia. Here you can see the tachycycle length is 331 milliseconds. It is a narrow QRS tachycardia, and PVC is given at the time of his bundle. When it is given at the time of his bundle, it has produced an A and a V after the his signal, but there is no change in AA interval. But after the next A, the tachycardia terminates. So one of the theories postulated in this case is a concealed nodoventricular pathway. See, if you look at this AV nodal reentrant tachycardia circuit, you can see this is an AV nodal reentrant circuit, slow pathway on one side, fast pathway on the other side. Slow pathway is antigrade, fast pathway is retrograde. This is the his bundle signal going down to the QRS. If there is something in some pathway like a nodoventricular pathway which can enter into the fast pathway after the stimulus, it has to be a his synchronous PVC because it has to block in the his so that it does not enter into the AV node. But through the concealed nodoventricular pathway, it affects the fast pathway, blocks in the fast pathway in antigrade and retrograde direction, and terminates the tachycardia. But it gives the slow pathway time to come around and terminate, enter the AV nodal circuit and his bundle. So even though it terminates the tachycardia in the fast pathway, the slow pathway conduction can proceed antigradely. A very rare observation in a concealed nodoventricular pathway. So the advice is whenever you do a his synchronous PVC, whenever you are giving a PVC at the timing of his, you look at so many things like not only advancement and resetting, termination, and how it terminates. Does it terminate without producing an A wave? Does it produce after producing an A wave without atrial advancement, like in this rare case of concealed nodoventricular pathway? And so many things as a beginner you have to observe, and if there is any doubt, you have to refer back to the literature because this is a very important maneuver. Similarly, one more example I would like to show is
so Anis, if there are complex examples, we can probably do the discussion.
Yeah, that's just the last slide. Similar to advancement, you can also delay the HH, delay the A, if it's an accessory pathway which has a decremental property. So this is another example of a synchronous PVC delaying the next day and producing a resetting of tachycardia. So in short, RP tachycardias, synchronous PVC differentiates between AVNRT and AVRT. In long RP tachycardias, it differentiates between atypical AVNRT and slow conducting accessory pathways and rare cases of nodovascular pathway. So this has already been discussed. Thank you. Yeah.
Great presentation. Suchit, very nice ladder diagrams. Your comments.
Yeah, I think yeah, Anis sir is an excellent teacher. I have been trained also by him. So I understand that he has done it so lucidly, and I think he has touched upon everything possible. So my take is that what he has said, that my idea is that whenever we are doing this, we should try to give the VPC from near the postulated location of the pathway. That is also very important. So if we give from far away place, it is not going to reset. For example, it is not also important to give, it may not reset a left lateral pathway causing orthodynamic AVRT if you are going from the right ventricle. So these things are very important to go near the pathway and give his synchronous VPC, and anything that pulls, delays or terminates is very much important, because if it is truly his synchronous. Anything more, Anis sir, to add to it?
So Anis, the most important value of this is obviously in narrow QRS tachycardia to differentiate a AVNRT from a posturoseptal pathway, isn't it?
Yes.
And
Is involved. Yeah. Yeah.
correct. And how do you time the most important for somebody who might be not doing it regularly but wondering how you give the his synchronous PVC? The EP system obviously senses the QRS,
Yeah,
and you can, can you just say a few things?
So during the tachycardia, you are giving an extra stimulus in the ventricle, and the timing it's a single extra stimulus which is timed to the R signal or the signal from the ventricle itself. So you will start at a cycle length of almost equal to the tachycardia cycle length. So
Right.
what the algorithm will do is it will look at the R wave, the signal in the ventricle, and then suppose the tachycardia cycle length is say 400 milliseconds, it will give the next stimulus at 380 milliseconds. So each time with each run, it advances the stimulus, and you can see that the initial first stimulus will not capture the ventricle because the ventricle is already activated through the His bundle. Then it starts capturing the ventricle with fusion beats, and finally the timing, when you look at it, the timing of the stimulus should be in time with the His bundle signal. And at that time, usually the QRS complex is not fused or sometimes fused, and then you have to look at the AA timing.
Right. So that might simplify it for the people who have just started how to deliver the extra stimuli and eventually find that one is really his synchronous. Sujit, can we move on?
Yeah, I think we can move on to the next presentation. I think Dr. Arun Gopi will moderate the next one.
So Dr. Arun Gopal will present the Parahisian pacing, and
Presentation
let's
moderate by,
ask Dr. Karthikeya to moderate. Yeah, sure. Arun.
Yeah. I think 1 second, I'll try to share my screen. So are my slides visible, and am I audible?
Yes, very much.
So I think, okay. Yeah. So after, I think, very illustrative classes by Dr. Sam and Dr. Anis on 2 important maneuvers, I go to the third one, which is essentially done in sinus rhythm. Next in the next 10 minutes, we talk on Parahisian pacing. We understand what is the basic principle behind it, how it needs to be done. How do you interpret basic Parahisian pacing, the limitations of this technique? So why do Parahisian pacing? Parahisian site is very unique in the sense that it is anatomically very close to the native His or the His Purkinje system. but electrically distant from it. So Parahisian site is anatomically close to the His bundle, but electrically distant because the His bundle is insulated. Essentially, it is done in simple terms to exclude the presence of a septal AV bypass tract, especially when you have a short RP narrow QRS tachycardia with a retrograde atrial activation sequence, which is concentric and just similar to what you see in a typical AV nodal reentry. It could be, so whenever you have a narrow QRS tachycardia, short RP, with concentric atrial activation sequence at the earliest atrial activation in the proximal His bundle, it could be a typical AVNRT or an orthotomic AVRT mediated by a septal AV bypass. In such a scenario, Parahisian pacing done in sinus rhythm gives us a clear insight whether at baseline a retrogradely conducting septal AV bypass tract is present or not. So whenever you have a central pattern of retrograde activation, Parahisian pacing gives us an idea whether the central pattern of retrograde atrial activation, that means central means coming from the earliest activation being in the His or the proximal CS and the concentric CS activation. It is whether it is due to an AV nodal conduction alone, or it is due to an AV node and accessory pathway, or it is due to an accessory pathway alone. So typically how it is done. In an ideal scenario, you require two quadripolar catheters, one for pacing and one for recording from the Parahisian side. Or you can also do it with a single octapolar catheter, that means 8 electrode catheter, where the distal part is used for pacing and the proximal part is used for recording, placed in the distal His bundle right bundle region. Most of the time, what we do is a single quadripolar His bundle catheter, which is actually placed at the site of the His bundle right bundle location, is used to pace from the distal site. But when you do with a single quadripolar catheter, it limits your ability to record the retrograde His potential and thereby limits your ability to measure the HE. And sometimes this might be useful. The key thing is whenever you are pacing, the catheter used for Parahisian pacing, you need to minimize the A signal so as to ensure that you don't capture the atrium. You don't capture the atrium near the His bundle. So this is the typical ideal scenario. This is actually taken from the pioneer in this, that is Jackman's publication in Heart Rhythm 2005. The typical way, as Sam initially told, it's actually a 4-catheter study. You have one decapolar catheter in the coronary sinus, one RA catheter in the RA appendage. You have the His bundle catheter. So the Jackman way of doing it is to have an octopolar catheter. You can see there are 8 poles. An octopolar catheter placed in the His bundle location, His bundle right bundle location. And then this is the Parahisian pacing catheter. The ideal site for Parahisian pacing is typically 5 millimeter anterior and apical to the His bundle. So at this site, you generally should have a large V or His bundle or right bundle potential and least amount of A or minimal A. So this is the typical site for Parahisian pacing. To minimize the catheter, some people even do an octopolar catheter placed here and place from the distal catheter and record from the proximal catheter. But if done with these kind of catheter setup, you have all the recordings which you require for all the, and it gives you tremendous amount of information because you have the Parahisian catheter placed here, 5 millimeter anterior and apical to the His bundle. That loses out the A signal, ensures there is no capture of the Parahisian atrial myocardium. And it ensures you have a good recording from the His bundle location with the octopolar catheter. So the principle of Parahisian pacing is you pace at a slightly longer cycle length, say around 500 milliseconds, at high output from the Parahisian pacing catheter as location I told, with a good His signal on the catheter and absolutely no A. Whenever you have a His bundle capture, whenever you have His bundle or right bundle capture, you tend to have a narrow complex. typical to your his bundle pacing. People who have been seeing conduct system pacing, when you have a his bundle capture, you typically tend to have a narrow complex. And then you can alter either the pacing output or the pulse width, which can be decreased until you lose his bundle capture. And the moment you lose his bundle capture, the QRS starts widening. So the pacing output is increased and decreased to gain and lose his bundle capture, while always you have the local ventricular capture, which is always maintained. So local ventricular capture is always maintained, but as you increase the output or increase the pulse width, you gain on his bundle capture, getting a narrow QRS, and as you lose his bundle capture, you tend to have a wide QRS. As I said again, you need to minimize the atrial signal seen on the pacing electrode to ensure avoidance of local atrial capture during the Parahisian pacing. So schematically, suppose you don't have a pathway. So look at the scenario where you don't have a pathway and you have only AV node conducting retrogradely, causing a central retrograde atrial activation pattern. So suppose in this scenario, you pace and you capture the His bundle. So you're capturing the His bundle. You would have you have a capture of His bundle in the first signal. You have a narrow QRS. You have a narrow QRS, which would simulate the sinus QRS. You have a narrow QRS. And here, the atrial activation is via the AV node, and you tend to have a shorter stim to A time. The atrial activation is via the AV node. Since you have captured the His bundle, the atrial activation is via the AV node, and you have a narrow QRS and a shorter stim to A. In a person with only a retrograde conduction through the AV node, suppose you lose his bundle capture. The next scenario this is when you have captured initially at high output, captured the His Perkins system, got a narrow QRS, had a shorter stim to A. Now you decrease the output, gradually decrease the output, you lose the His Perkins system capture. So here, the importance of Parahisian site, as I said, is you are anatomically close to the His Perkins system, but since the His Perkins system is insulated, at low output, whenever you capture the ventricular myocardium close to the His Perkins system, you cannot directly capture the ventricular the His Perkins system. The His Perkins system actually loses its insulation near the RV apex, where it loses insulation and gets into the myocardium. That is the exit site of the His Perkins system. So when you lose His Perkins capture, such a stimulus has to travel down all the way to the RV apex, get into the exit of the His Perkins system, and then go retrograde back through the His Perkins system and get back to the atrium. So in a condition where you have only retrograde activation via the AV node, when you lose His Perkins system on capture, so here the second complex, you have lost His Perkins system capture as evidenced by a wide QRS. You have lost the His Perkins system capture, so the impulse actually goes all the way to the RV apex, gets into the exit of the His Perkins system, and then comes back through the His Perkins system, and then reaches the AV node retrogradely, and then gets into the atrium. So the time delay is too much, and that is why you tend to have a longer stim to A. So in simple terms, whenever you have a retrograde central atrial activation, concentric atrial activation pattern being via the AV node alone, with His bundle capture, you have a narrow QRS and a shorter stim to A. And with loss of His bundle capture, you have a broad QRS and longer stim to A. Now think of this second scenario where you have a septal AV bypass tract. So in such a scenario, when you do Parahisian pacing, if you have captured the His bundle or not, you have always a septal bypass tract contracting up. So if you, in the first template, you have captured the His Perkins system, as you see, you have a narrow QRS. Your stim to A is narrow because your stim to A is only dependent upon the time of the local V near the accessory pathway. So your atrial activation is via the accessory pathway, and the only determinant of the atrial activation is actually the local V near the accessory pathway. So you have a narrow QRS from His Perkins system, or your broad QRS from the loss of His Perkins system capture. Your stim to A will essentially be same because your conduction to the atrium is only dependent upon the activation of the ventricular myocardium near the accessory pathway. So even if you lose this bundle capture, you'll still go to the accessory pathway and you'll have a similar SA. So this is stim to A, that is called SA. So whenever there's a septal AV bypass track, you capture the His-Perkins system, get a narrow QRS, or you lose His-Perkins system and get a broad QRS. Your stim to A essentially is always same, because the only thing that determines the atrial activation and the stim to A time is the time of activation of the local ventricle near the accessory path. On the other hand, the earlier scenario, the thing that decides the atrial activation sequence as well as the atrial activation time, the stim to A time, is actually the time it takes to the His-Perkins system. So the atrial activation sequence would be same if you have only one way of going back. But the timing, the SA timing, the HA timing, or rather HA timing will always be same. The atrial activation is actually dependent upon the timing of the His bundle activation. So HA timing in this always will be same, because only once it gets the His bundle, it can get to the local atrium or that is only exit R. So the HA timing, irrespective of you have captured the His-Perkins system or you lost the capture in the His-Perkins system, the HA timing will always be same when the retrograde conduction is through an AV node. The SA timings actually depend upon whether you have captured the His-Perkins system or not. So when you're interpreting the Parahisian pacing, you essentially look at 4 variables, whether you captured the His-Perkins system or not. As I said, you always need to ensure local ventricular capture and no atrial capture. The 4 variables that you look at is the atrial activation sequence and SA interval. For most of the beginners, these 2 things would suffice. You need to look at the atrial activation sequence and the SA interval. For more in-depth interpretation, a local VA at the site of earliest A in an SVT can also be looked at. And an HA interval, for which you actually require 2 quadripolar catheters or an octopolar catheter, as I said, pacing from the distal electrode and recording from the proximal electrode. So schematically, I'm just trying to explain the same thing again. It's just about principles. I'm not going to show much of case-based scenarios. So if you have only a retrograde accessory pathway conduction, as I said, you look at essentially 3 aspects. One is the atrial activation sequence. So you have only one way to go out. You have only the retrograde accessory pathway conduction. So atrial activation sequence, whether you capture His bundle or you lose His bundle capture, the atrial activation sequence will be same. The atrial activation sequence, since it has only one way to get to the atrium, it will be same. The stim to A in a person with a retrogradely conducting accessory pathway, it will be same whether you capture His bundle or you lose His bundle capture, because essentially the stim to A is decided by the ventricular myocardial activation near the accessory pathway. So stim to A, whether you gain or lose His bundle per His-Perkins capture, will remain the same. But whenever you actually captured the His-Perkins system, you tend to have a shorter HA when you have an accessory pathway. Now, on the other hand, when you have only a retrograde conduction via AV node, when you have a central concentric atrial activation, if you have only a retrograde activation via AV node, the atrial activation sequence again will be identical, whether you capture or lose His-Perkins system capture. Since there is only one exit to the atrium, the atrial activation sequence will essentially remain same. The stim to A time, the moment you capture His-Perkins system will be shorter, and when you lose His-Perkins system, the SA time will be longer, because you have to go all the way, as I said, to the apex, get in the His-Perkins system and get back. But you can only enter the atrium by the His-Perkins system. So the HA time will always be same whether you capture or lose His bundle capture. So the atrial, in simple terms, when you have only one conducting pathway, whether it's accessory pathway or AV node, the atrial activation sequence will always be same whether you lose or gain capture. The the atrial activation in an accessory pathway is totally dependent upon the activation of the ventricular myocardium near the accessory pathway. So the HA times tend to be shorter when you lose his Purkinje capture, while STIM2A will remain same whether you gain or lose his Purkinje capture. Well, when you have a retrograde AV nodal conduction, the atrial activation is totally dependent upon the timing of his bundle capture, his bundle activation. And so HA time will always be same, irrespective of you gain or lose his Purkinje capture. But your STIM2A will be longer when you lose his Purkinje capture. Now, the third scenario is when you have a fusion activation of the atrium via both accessory pathway and AV node. For simple terms, just understand that when you have fusion activation, that is retrograde conduction via both accessory pathway and AV node, your atrial activation sequence will be different when you captured the His-Purkinje system and when you lost his bundle system capture. The SA interval and HA interval will actually depend upon where you're measuring. In fact, the SA interval will be same near the accessory pathway. SA interval will be longer if you're recording from the central area, while HA will again be same or shorter depending upon how much of part is activated via AV node, how much is activated via accessory pathway. So the algorithm is, when you're doing a Parahisian pacing, gain his bundle capture with high output, go reduce on your output or pulse width, lose his bundle capture. Between the two, look at the atrial activation sequence. If the atrial activation sequence is identical, that means you have only one way of going up the atrium. That means you have either going via accessory pathway or AV node. But if you have different atrial activation sequence with loss of his bundle capture, you have two ways of going up, and that means you are actually, whenever you have a different atrial activation sequence, you have both atrium, both AV node and accessory pathway conduct. But if you have a single atrial activation sequence, same atrial activation sequence, then the next is to measure the STIM2A. Then also measure the local VA, but you go by measuring the STIM2A. And if your STIM2A is same, irrespective of whether you gain or lose his bundle capture, you tend to have accessory pathway conduction only. And in these scenarios, you tend to have a shorter HA with loss of his bundle capture. On the other hand, if you have a longer STIM2A with loss of his bundle capture, you tend to have only AV nodal conduction. And here, atrial activation is totally dependent upon timing of his activation. And so the HA will always remain same. You have different activation sequence. You have both AP and accessory pathway and AV nodal conduction. There's actually a seminal publication by Kenzo Hiraro in Circulation 1996, where they have gone on and described seven different patterns, which would actually be beyond the scope of discussion for the beginners. I'll just stick to the commonest types. As I said, when you have only AV nodal conduction pattern, just going through it again, because it's just three concepts. Whenever his bundle is captured, you have a shorter SA. And when only ventricle is captured, you have longer SA. You won't have a change in atrial activation sequence. This pattern is typically seen in all patients with AV nodal reentry. It is never observed in any patient with a septal AV bypass tract or a right free wall bypass tract. But you should be remembering that it can be observed in some patients with left free wall or a decrementally conducting accessory pathway like a PJRT, where the retrograde AV nodal conduction can in fact mask the presence of a retrograde bypass tract. So just illustrating. So this is the typical, I said, Jackman way of doing it. When you have an octapolar catheter in the his bundle and a Parahisian separate pacing catheter, you get all these sharp signals when. So when you see this signal, the first thing is to see whether you have captured his or not. So the first thing you have captured his, you can see the stim to his is just 10 milliseconds and you have a narrow QRS. The second complex, your stim to his is 70 milliseconds and you have a broad QRS. So here you have lost his capture, you have gained his capture. So now you understood that you have got a gain and loss of his capture. Now the second step in this is to look at the atrial activation sequence. It is just the same. You have the earliest atrial activation in CS proximal, and then you have a concentric activation pattern. Here also the earliest atrial activation is CS proximal. So gain or loss of it, when you have lost his bundle capture, your atrial activation sequence remains same. So second step is to look at the SA interval. So your SA interval is 120 milliseconds when you have gained his bundle capture, and is 180 milliseconds when you have lost his bundle capture. So there's lengthening of SA interval with loss of his bundle capture, indicating a retrograde conduction through an AV node. Now, if you look at the numbers, it's very self-explanatory. You see when you have gained his bundle capture, you have a stim to his of 10 milliseconds. When you lost his bundle capture, your stim to his is 70 milliseconds. So that means it took 60 milliseconds from the Parahisian myocardium to go up to the RV apex, come down the His-Perkins system, get back to the His. So this 60 millisecond extra time from the stimulus to the His explains the difference in the SA time from 120 to 180. The 70 minus 10 of 60 milliseconds explains the difference or the lengthening of the SA interval from a narrow QRS SA of 120 to a broad QRS loss of his bundle capture of 180 milliseconds. So everything is mathematically, you are exactly going on time. So here we say it is low AV nodal input because the earliest activation is in the CS bronze. Again, the typical pattern seen in AV NRT. Broad QRS because you have lost his bundle capture, stim to his is 60 milliseconds. Here you have narrow QRS, stim to his is 15 milliseconds. You see the atrial activation sequence, just same atrial activation sequence pattern. When you lose his bundle capture also, the atrial activation sequence remains same. So there's only one exit to the, only there's one way to get to up to the atrium. Look at the SA. The SA is 90 milliseconds when you have broad QRS or lost his bundle capture, and 45 milliseconds when you have narrow QRS or gained his bundle capture, suggesting typical nodal inputs. And again, the atrial HA time. The atrium is activated via the AV node, after his bundle activation. So the HA time essentially remains same. So HA time is 35 milliseconds, indicating that it is the AV node which is depolarizing the atrium, suggesting of a retrograde AV nodal input alone. Pattern 2, as I said, is to the bypass tract, where retrograde activation happens exclusively to the bypass tract. So the SA interval is identical whether you have gained or lost his bundle capture. And the retrograde active conduction, as I said, is only dependent upon the local ventricular activation and not on his bundle activation. Again, remember, when you see this pattern, it does not exclude the presence of retrograde activation over AV node with longer conduction time. If your AV node conduction is very slow, or it does not exclude the presence of a second bypass tract with longer conduction time located really far away from the pacing site. So again, this pattern, you see both the things. So here you have stim to his being 15 milliseconds and a narrow QRS. So here you have gained his bundle capture. Here you lost his bundle capture. You have stim to his of 70 milliseconds and you have a broad QRS. Now you see, so you have both gain and loss of his bundle capture. The second step is to see the atrial activation pattern. You have just similar atrial activation pattern with earliest atrial activation in the his bundle. That means you have dealing with either a nodal input or anteroseptal accessory pathway. Now look at the stim to A. The third step is stim to A. So stim to A is 95 milliseconds whether you have gained or lost his bundle capture. So the only thing that determines the SA timing here is the local ventricular activation near the accessory pathway. So when you have narrow QRS or broad QRS, the stim to A is same. That means you are conducting only via the accessory pathway up. And you see that whenever you have actually lost his bundle capture, your HA tends to be shorter. So your HA is actually shorter by from 80 milliseconds to 25 milliseconds whenever you have lost his bundle capture. So this is typical bypass tract bypass tract Parahisian response. There's one more bypass tract Parahisian response, which is where the accessory pathway is longer from the site of pacing, which again I would stay away from. And there's again subsequent patterns where you have fusion activation. I would just say that whenever you see this pattern, see you have gain and his bundle capture. So you have a short stim to H here and a short stim to H here with narrow QRS means his bundle capture, and a longer stim to H and broad QRS being loss of his bundle capture. You have a different atrial activation pattern. So atrial activation sequence is different. That means you have two ways to go up, both a pathway and AV node. I'll stop short of there, and the other patterns are beyond the scope of discussion here. But I would just finish off by making you understand some of the limitations of this maneuver. Whenever the bypass tract is located progressively far away from the Parahisian pacing site, the stim to ventricular bypass tract time increases progressively. So left lateral, and whenever you are dealing with the right free wall pathway or anterolateral pathway, you might have wrong responses. Parahisian pacing also fails to identify retrograde conduction over slowly conducting axillary pathways like PGRT. Parahisian pacing during sinus rhythm just helps to prove the presence or absence of a retrogradely conducting AV bypass tract, but it never says that the bypass tract is operative during the SVT. Whenever we have a very proximal retrograde right bundle block, a right bundle capture may fail to produce early retrograde activation of his bundle, limiting the use of Parahisian pacing. So final tips, you should always try it even if you don't need it. Remember that you should have a very sharp, good His bundle Purkinje signal, good His potential, and with absolutely no A potential wherever from the site you're doing Parahisian pacing, which is 5 mm typically anterior and apical to the site of his bundle location. Often apply a little clockwise torque, which will help you to gain his bundle capture. Start at 20 milliamperes output. Look for narrowish QRS. Bring the pacing output down. Look for wider QRS. Again, whenever you find a VA which is just too short, if the VA becomes less than 50 milliseconds, you are typically dealing with a concomitant atrial capture, Parahisian atrial capture. You are probably capturing the A also. Similarly, if VA in a techie is longer, more than 150 milliseconds, then the pathway is typically slowly conducting like a PGRT, and Parahisian pacing will typically look a nodal response. So this complex algorithm is beyond for beginners, but I'll leave you with this. Whenever you lose this bundle capture, just look at the atrial activation sequence. If it is identical, you have only one exit up. In that case, look at the SA. If the SA is same, you are conducting via the axillary pathway alone, and you'll typically have a shorter HA. While if the SA is longer, you typically demonstrates nodal Parahisian response, and here you'll always have a similar H to A because H is the driver for A. And if you have different atrial activation sequence with loss of his bundle capture, you have both axillary pathway and AV nodal conduction. So that's all from my side.
Thanks, Arun. I think that repetitive nature in this your presentation would have helped many of them to consolidate the concepts of Parahisian pacing and remove that anxiety. I think you'd be happy to know that there are many senior IHRS members on today's seminar. So I think they surely would have loved and appreciated your effort. Karthikeyan.
Yeah, so nice presentation, Arun, but little exhaustive. So may have confused beginners of EP or those who are wanting to join EP. So I like to just clarify a few things. First of all, this is a maneuver. It is done during sinus rhythm in contrast to the previous two maneuvers that we just saw. Secondly, his bundle site, as you rightly said, presents a unique site for pacing because it is electrically distinct but anatomically very close. His bundle itself and the surrounding RV myocardium, there are two distinct sites which are anatomically very close when we place a his catheter there, but they are electrically very different, very distant because of the insulation of the his bundle right bundle region. And so if you pace at high output, you will capture both. But if you pace at a lower output, you will capture only the right ventricular myocardium. Now, how to identify whether you have captured both or only the RV? The simplest thing is to look at the QRS width, which will be narrowish if you have both captured and wider if you have only myocardium captured. Quite logical, but may not always be true. So the best thing, confirmatory thing is to look at his signal. So it is just a general principle that if you pace from any signal and you have captured that signal, that will be pulled in. So if you capture both RV and his and capture the stim to his time will be very short and his actually won't be visible at all. Whereas if you just capture the myocardium but do not capture the stim to his time will be longer. So this is a general principle of electrophysiology and very well applies to Parahisian pacing itself also. Now, next thing is when to do this maneuver and what is the utility. Now, utility, as you rightly said, is to distinguish the retrograde mode of conduction, whether it is an AV node alone or a septal accessory pathway. I'm just saying septal because it will also recognize lateral pathways, but they are much easier ways to look at lateral accessory pathways than this maneuver, which may give very confusing and difficult to interpret tracings than the other thing just looking like the earliest activation in the atria. Also remember that septal accessory pathway, which are slow conducting, may not be very well delineated with this maneuver because your AV nodal pathway conduction will remain much faster than the pathway conduction. And so pathway conduction will never get apparent on this maneuver. So the way we look at is we differentiate whether there is only AV nodal conduction or there is a septal accessory pathway conduction alone or there is conduction to the both. Now, next principle. Now, if you have different activation sequences in the atria, when you capture the His and you lose capture, that means there are two routes of conduction. So you are clear that there is one AV nodal conduction and an accessory pathway conduction. So that is one simple principle, and that should be the first step when you analyze a tracing with Parahisian pathway. Second thing is, the second principle is you have to look at the stim to A interval when you have His capture versus when you do not have His capture. And the principle is that you have to realize whether your atrial activation timing has been dependent on His activation timing. That means that if you have delayed His conduction, but your atrial activation timings remains the same, that means your atrial activation is not dependent on His activation, and hence this has to be through an accessory pathway. On the other hand, if you delayed His timing while you lose capture, and you delayed the atrial timing to the same degree, that means your atrial activation is dependent on His activation, and that means you have only AV nodal conduction. So this is a general principle, whatever tracing or pattern that you may see. So based on these, we can define whether it is a only AV nodal conduction, only pathway conduction, or you have both. A few caveats. Now we know that AV node has decremental properties. So when you pace at a high output and then a low output, you will have transition from His capture to loss of His capture, and that is very well okay. But if you do it in the other way around, that you pace at a low output and then you pace at a high output, that is, you have no His capture and then subsequently His capture, your His timing gets shortened. And so there may be decrementally delay in AV nodal conduction, and that may give fallaciously wrong results. And so I would suggest that whatever tips you have described, always add to this, that whenever you do it, you do at a high output first and then at a low output to see transition from His capture to loss of His capture when you analyze this rhythm. So I think I'll end with this, and just remember these principles and then also see what you are looking for while doing this maneuver. And if you utilize these principles, you will be able to figure out different and complex tracing that may arise with this simple maneuver. Dr. Arun, Ashish.
I think we should move on, or
I think we are way behind time, so it's 11:50. I think we should go for
yeah.
the
So the next one is a case presentation by Dr. Amida Shaikh. Please, let's begin it.
Hello.
Yeah, you are audible.
Yes, sir. Good morning, everyone. So we are having some case discussion on the CP-based maneuvers that we have just discussed. So starting with case one, actually I have three cases. I'll try to go a little fast as well as try to be a little explanative also. So we have a 34-year-old male with incessant SVT for 2 days, responsive to IV adenosine. However, the tachycardia would initiate easily with VPCs again. Tachycardia termination was attempted in a peripheral center with IV amiodarone, IV dilsem, and cardioversion. However, the tachycardia would terminate, convert to sinus rhythm, again initiate with premature complexes. LVEF during ongoing SVT was around 30%, so we had a component of tachycardiomyopathy. This was the ECG. This is a long RP tachycardia. You can see RP here, long RP tachycardia with negative P waves in the inferior leads, plus a component of QRS alterans that we can see in the precordial leads. This is the ECG in an expanded form in the EP lab, showing similar P waves and long RP narrow complex tachycardia. So what are our differential diagnoses here? Permanent junctional reciprocating tachycardia, atypical AVNRT, CS off-stim tachycardia, nodovascular tachycardia, nodoventricular tachycardia. Here we are going to differentiate among the first 3 causes. They are the most common causes of long RP tachycardia. So interestingly, when we were put, so this is an interesting ECG and EGM picture. So in the initial half, we have tachycardia ongoing. Subsequently, there's tachycardia termination followed by sinus rhythm. So in sinus rhythm, we are seeing a normal atrial sequential pattern followed by a His signal and V. Like Dr. Sushit said initially, we see the HV interval during tachycardia and HV interval during sinus rhythm. It is same. So this is ongoing SVT. But we know that characteristic from the ECG itself that it is a narrow complex tachycardia. Now, how this tachycardia has terminated? We have a His catheter placed and we are attempting to put a CS catheter here. So what has happened here? These are the atrial signals followed by the small ventricular signals here, and there is a premature atrial complex which has come in and terminated the tachycardia. Now, if this was a spontaneous termination of tachycardia with a premature atrial complex, we would have ruled out the atrial tachycardia. However, this is not a spontaneous termination. This is an induced termination with catheter. So that is why we cannot reliably say that we have ruled out atrial tachycardia with this termination. Next, we are starting with Parahisian pacing. Now, in Parahisian pacing, this is the transition zone which I'm describing here. So we have a narrow complex followed by a wide complex QRS that we can see here. So during his capture, that is when there is a narrow QRS, we see the atrial sequence. So this atrial sequence is similar to that where we have lost a His capture. We measure the S to A interval, and S to A interval is different, wherein the S to A interval has prolonged to 145 milliseconds when there is loss of His capture or only myocardial capture. So this is a nodal response. So when we get a nodal response, we do exclude a septal pathway, but we do not exclude a septal decrementally conducting pathway. Like we have PJRT as a suspicion in this tachycardia. We do not also exclude a left lateral pathway in this particular maneuver. So like we described, this was a nodal response that we got. Now, okay. V-pacing, when we have done V-pacing, there is a concentric response to the tachycardia. Now, what is concentric response? We see the retrograde atrial activation. The retrograde atrial activation is earliest in His, followed by CS proximal, and then further down into the CS distal dipoles. Now, this kind of rules out a left lateral pathway, because if there was a left lateral pathway, we would get typically an eccentric activation pattern with ventricular pacing. So this would be our activation pattern with eccentric activation pattern. CS1-2 typically would be early, that is located in the distal annulus or the lateral annulus, followed by that activation would proceed towards proximal CS electrodes. So now we have initiated the tachycardia, and this particular tachycardia got initiated with a V pacing, a V extra stimulus. and with a critical prolongation of the VH interval. Now we see this tachycardia here is a long RP tachycardia. RP. This is a long RP tachycardia with activation sequence of CS910 from CS12. So it is a concentric activation pattern which is happening here. So now next maneuver when we do his refractory VPC. We are putting a his refractory VPC here and trying to analyze what has happened to the AA intervals. So we know this is his refractory because we have got the pacing interval here just before the expected hiss that would come here after the A beat. So now that we have paced here, we measure what has happened to the AA interval in the subsequent response. Now the AA has not changed in the next beat. Now this, whenever the A gets shortened or A gets lengthened, we know that the pathway is involved. What happens if the AA does not get changed? Now in that scenario, we cannot rule out pathway. Pathway can still be present. So next maneuver we are doing is an entrainment maneuver. In entrainment, we are this tachycardia at that time was going at around 290 milliseconds, 285 to 90 milliseconds. So here we are trying to pace a little faster than that. What we got to observe here is the transition zone. Transition zone, what Sir described earlier, was progressive fusion from the tachycardia morphology to the pace morphology. And in the square, we notice that there is a change in morphology. If you see the channel 2, there is a change in morphology which is happening. Until it stabilizes, it takes about 5 to 6 beats. Now, this is more in favor of AVNRT. If there was a right-sided septal pathway, this transition would have happened in 1 or 2 beats only. Now coming to the entrainment response, what did we get? Now this is a long RP tachycardia. We have to be careful while analyzing the PPI, the response actually when we get during entrainment. When we see it without, what do we have to do here when we interpret the entrainment response? We have to check whether we have reset the A when we are pacing the ventricle. So we know that the tachycardia is going on at 285 milliseconds. We pace V. When we pace V at 270 milliseconds, we have to confirm whether we have got atrial resetting or atrial capture. So we have to measure the AA interval. Here we have ensured that the AA interval is 270 milliseconds, which is the same as pacing cycle length. Now we have to see which is the last entrained atrial beat. For that, particularly in long RP tachycardias, we have to be careful to note which is the last entrained beat. And this we will get only by measuring. And we know that this is the last entrained beat for this paced V. So then we interpret the response as VAHV response. In this, when we get a VAHV response, we know that atrial tachycardia is ruled out. Next, we see PPI minus TCL. Post-pacing interval minus tachycardia cycle length here is 195 milliseconds, so more than 115. So this is in favor of AVNRT. Also, SA minus VA. SA minus VA more than 85 is suggestive of AVNRT. So this was atypical AVNRT. And we located the earliest aid during activation mapping, and we found out near the inferior extension. We ablated that. We also modified the slow pathway. Now, in the second case scenario, we have a 16-year-old male presenting with intermittent palpitation. This patient had neck pulsations. Now, when we get this history of neck pulsations, we know that simultaneous VA activation is happening. So, more in favor of AVNRT according to history only. Frequency had increased over the last 3 months and tachycardia was adenosine sensitive. Now, this is the ECG. In ECG, we see narrow QRS tachycardia. We see pseudo S waves in the inferior leads and pseudo R waves in V1. So we know that we are dealing more or less with AVNRT. But very rarely, when we have fused septal activation, we may get a scenario wherein we're dealing with atrial tachycardia utilizing a slow AV nodal pathway for conduction or junctional tachycardia. In this particular EGMs, we are going to differentiate AVNRT versus atrial tachycardia. All right, so this is the sinus rhythm EGMs. So we see now the ablation catheter is at lateral RA. So RA is the first atrial signal here, followed by His, followed by the CS proximal to distal activation. This is the V and this is the H. So okay, so we have done Parahisian maneuver here. Parahisian maneuver is revealing similar kind of response which I showed in the previous case. This is a narrow complex which is a His capture. This is a wide complex which is the muscle capture or loss of His capture. During that, the sequence of A is almost similar, and we have a measurement of 119 milliseconds during loss of His capture, which is in favor of nodal response. Then we induced a tachycardia. During induction, we have used extra stimulus here. Now we see this is S1, and this tachycardia is being induced with isoprenaline. So that is why the stimulus cycle lengths are shorter here. So 350 is the first stimulus. Second stimulus we have given is 300. The third stimulus is 220. Here we are measuring the stimulus to H interval. We can also measure the AH interval, but for a comparison, I just want to demonstrate AH jump. So this is 127 milliseconds. Next beat, when we have decremented the S3 by 10 milliseconds, we have got a jump from the stimulus to the His signal by more than 15 milliseconds. So this is a typical jump to the in AVNRT. Now, we have induced a tachycardia next. When we have induced tachycardia, what do we observe? We observe that the activation pattern is almost fused septal activation. We cannot make out the V and A separately because it is appearing in a fused pattern. If we see closely, this is the His signal. This is probably the surface A, and this is what is represented here in the initial part of the QRS, followed by V. So it is a AHV tachycardia. So then we place a His refractory VPC. We give it when the His is a refractory. So this is the signal here, which of the VPC. Then we measure the AA intervals. The AA intervals are not changing. So again, there is no cycle length change. So it does not rule out a pathway. Here, in the entrainment response. Now, when we get tachycardia, we get excited and we start entraining the tachycardia. We have to be sure of how we entrain it. So here, this is just done deliberately just to show what are the fallacies of entrainment. Now, we have entrained from the His catheter only. Now, what is the problem when we entrain the His catheter? Now, we got a wide complex. Now, we know that we are entraining here. Well, means we have got a wide complex in the surface ECG plus. If we measure the AA intervals, we are getting it entrained. The AA reset has happened. But in this scenario, what is happening is since the catheter is in the His location and A signals also might be present, there is simultaneous capture of V as well as A. That is why the SA interval is falsely narrow. We do not expect an SA interval of 55 milliseconds when we have a AV nodal conduction involved. So this is a false conduction because we are pacing at the wrong location. So this emphasizes the importance of doing this maneuver properly. So then we have placed the ablation catheter in the RV. So this is RV location, and we have started entrainment here. Now again, you see that there is a transition zone, and this is a transition zone here, marked here. And we see that there are about 3 or 4 beats involved. As I said previously, less than 2 beats means a right-sided or a right-sided free wall or a right-sided septal pathway. Right. So we are then interpreting the entrainment response. Now, in the entrainment response, one more thing I forgot to mention in the previous cases, you have to see what is the activation pattern of the atrium during the entrainment response. So when we are resetting, what is the atrial activation pattern? Whether it is same or it is changing as per when tachycardia is going on. So here we notice that the entrainment is the atrial activation during entrainment is similar to that of tachycardia. Because if it is different in activation, which I have a slide later on, that is in favor of atrial tachycardia. So now this activation pattern is similar. We confirm the AA cycle lengths that they are entrained, and we measure the SA minus VA. Now, if you notice, this VA is negative here because it was a AHV fused tachycardia. So here, SA minus VA will be actually plus 15. So it would be 158. This would be in favor of AVNRT. PPI minus TCL here was 195 and we had got a VAV response. So this is all in favor of AVNRT. So we did a slow pathway modification for this case. Case scenario 3. In this, we had a 44-year-old female with frequent episodic palpitations with sudden onset and termination. No associated neck pulsation or post-palpitation diuresis. This tachycardia was not terminating with IV adenosine and required a calcium channel blocker during the last ED admission, and patient was receiving oral verapamil. So this is the tachycardia ECG. Again, narrow complex tachycardia. What we are seeing here is probably these are the P waves. So we can see distinct P waves here. So it is a short RP tachycardia only, but we are seeing distinct P waves. So more, and it's a very fast tachycardia. So more likely that this is probably pathway mediated tachycardia. And yes, when we induce the tachycardia, this is the tachycardia that we have got around 300 milliseconds as the cycle length, and the activation pattern is eccentric. So we know that there is something in the left which is involved. So what are the differentials when we get this kind of a response? So it could be a ORT, which is mediated to a left lateral pathway. It could be a left-sided atrial tachycardia, or it could be a junctional tachycardia with left lateral accessory pathway presenting as a bystander. In this scenario, we are with the 3 pacing maneuvers described before, we are going to differentiate between these two, the first two causes, orthotropic AVRT versus left-sided AT. Now, going back, when we do V pacing to check for VA conduction, what we notice here is that we have concentric pattern till block. Normally, when we get an activation pattern like this during tachycardia, we also expect that during V pacing, we get an eccentric pattern, but it is not always necessary. It can happen because of the refractory periods of the pathway and AV load being almost the same. So we may not be able to demonstrate eccentricity with V pacing. To obliterate this, we have to actually go into the LV and pace, and we would be able to demonstrate an eccentric pattern during V pacing also. So that is what, okay. So in this, we have demonstrated the effect of his refractory VPC. So what is happening here? The his sync VPC is being given here, and the next A has been pulled by some 25 milliseconds. So there is a significant pull in. So this is most probably a pathway mediated tachycardia. Next, when we entrain and check the entrainment response, PPI minus, okay, before that, when we check the entrainment response, we check how is the eccentricity during the tachycardia and during entrainment. So during entrainment also, it is the same eccentricity, and during tachycardia also, it is the same eccentricity. If there was a difference, it could be atrial tachycardia from a different origin. I have a EGM for that subsequently coming up. So this is the activation remains same. Next, we are interpreting the PPI minus TCL. PPI minus TCL here is to 50 and SA minus VA is 25. All this are in favor of a pathway mediated tachycardia. So this completes my description of 3 cases, and I have some interesting EGMs here, just describing various responses that we get during the maneuvers. So this is entrainment response describing a V response. And in this, if you notice, when we are pacing, when we are trying to entrain, the activation pattern is different than the activation pattern during tachycardia. So this, when you look at it only, this goes more in favor of atrial tachycardia. Plus the VAAHV response also is in favor of atrial tachycardia. This is the fallacy of Parahisian pacing. When we do Parahisian pacing, we have to make sure, like Dr. Arun said, we don't have A capture. And we know that because the VA interval here is just 55 milliseconds. Now, this is in the HRA, and we're supposed to have less than 90 milliseconds here. So, if we get a very short stim to A distance, then we always have to suspect that we have a capture here in Parahisian pacing. Now, this is, we know about advancement of the AA interval. This is delay in the AA interval with his refractory VPC. Whenever there is a delay, Anisa just touched about it. This is suggestive of a decrementally conducting septal pathway. When we have tachycardias without 1:1 AV association, these maneuvers cannot be used. So there are other ways in such scenario. So we have to have 1:1 association. We cannot interpret these pacing maneuvers when we don't have 1:1 tachycardia. Also, it can, this is my last slide, it is possible that while doing entrainment, sometimes we are not able to entrain the circuit. This is because of cycle length wobble, which can happen. So if you see here, we are trying to pace it 280, but the atrium is not getting reset. It is at 312 here. So this is possible when there is cycle length wobble, and this is characteristic, typically occurs with atrial tachycardia. So repeated attempts we are trying to, and we are not able to entrain, means it goes in favor of atrial tachycardia. So my take-home messages are here not all SVTs need maneuver to establish a diagnosis. So we can see the pattern and we can analyze, but SVT maneuvers involving ventricular pacing are extremely essential in a situation of long RP tachycardia with varied differentials, like we described in the first case. It is very, very important in that scenario. It can be also used to re-evaluate the tachycardia during unsuccessful attempts of ablation. We are trying to ablate, but it's not ablating. The tachycardia is not terminating. Then we have to reanalyze the situation by using maneuvers and be sure of our diagnosis. And pacing maneuvers should be performed in a specific pattern, otherwise there are fallacious results, like how we saw in entrainment. In a hurried way, if we try to pace in a hiss, what would happen? And what would happen if we have a signal in the hiss catheter while doing a Parahisian pacing? Thank you.
Very exemplary cases, Samira. Suchit?
Yeah, I think the first case is very beautiful. Means in a decremental pathway, how these maneuvers are important. Means I think that entrainment response sometimes can be difficult to differentiate between a septal decremental accessory pathway and atypical AVNRT. But often I find that this is somewhat useful when we do a his refractory PVC. It somehow perturbs the circuit. In AVNRT, it is difficult to perturb the atrial. Means it may delay, but it perturbs the circuit somehow. That is my idea. The last thing what she has said is also very important in a left lateral pathway. If you often don't need the maneuvers, and often those maneuvers doesn't work well, especially if you have an entrainment response. Usually often the entrainment response will be like an AVNRT because it is far away. And secondly, the lateral pathway is only engaged easily after the capture of the hiss and going down through the conduction system to the left side and then conducting the pathway. So it is myocardial to pathway versus conduction system to pathway capture rather in left lateral pathway.
Sure. I think wonderful seminar with good take-home points and different aspects dealt with. Let's strictly have, meaning the simple EP was also shown, and when to do maneuvers was also highlighted, not making it very eccentric towards requiring maneuvers in all the cases and creating a fear of doing a SVT case. I think very exemplary organization of the whole meeting. Let's have one final word from, let's say, Karthikeya, followed by Arun, and then Anis, and then we can close down. Karthikeya.
Yeah, wonderful presentations by everybody, and I think this is going to be of immense use to all our DNB students, and in fact generate more interest among them in choosing EP as their career option. The last thing that again, whenever you do an EP study, look at the maneuver that you want to choose based on what you want to seize. So just giving a final example, for example, if you have a long RP tachycardia, you know that Parahisian pacing will not be useful because the diagnosis that you are dealing with are either atrial tachycardia or a slow conducting accessory pathway or atypical AVNRT. And in none of these cases, Parahisian pacing response will be useful. So it is very important to understand the principles, the general concepts, and then apply those knowledge of your electrophysiology to in a particular specific situation to make a diagnosis quickly and accurately. Thank
Right.
you
So
so much, everybody, for
sure.
being
Anis,
there.
maybe first and then Arun to take the last word. Anis? Anis has left or yeah. Then Arun, you can take the last word and we can.
Yeah. So I think for juniors, I just have to say, whenever you deal with tachycardias, go systematically. Start from the ECG, understand what your differentials on ECG are. Take the patient to the lab, induce it. When you see the tachycardia, sit back, first observe it. Again, based on the baseline observation you see in sinus rhythm, as well as during tachycardia, again, narrow down your differentials. And then, as described here, apply appropriate maneuvers for the particular case rather than going on doing all the maneuvers in particular case. Whenever you do the maneuver, understand how it has to be properly done and how it has to be interpreted. Understand the fallacies. Go again on the tracing step by step rather than jumping into a pattern recognition and going quickly on and ablating. Do selective maneuvers, understand and go and slow and interpret it again. And then finally, again, if you're finding that you're getting nowhere, revisit the tracings again and ensure that you've done it properly and you're not missed out anything.
Yeah, beautiful, Arun. And I think before we end, just a reminder for those who have attended, you can revise your concepts. This webinar is obviously put on the IHRS website. You don't have to be IHRS member to access that webinar. It is before you log into the IHRS website. So it's easily accessible to those who have attended to revise the concepts. And please pass on the word to your colleagues in the department that they can, this was a very good seminar and that they can even first-hand visit it at their time of convenience. So thank you very much, Arun. Thanks, Karthikeya and Suchit for moderating this very well. And I think we'll keep doing this on the first Sunday every month. Next time it will be from Dr. John Roshan from the CMC Vellore. I think it promises again to be a good one. Thanks, everybody, and goodbye to you all. Bye-bye.
Thank you, sir. Thank you.